Just now, when to give antibiotic, what antibiotic to give, what antibiotic lah. Okay, so pediatric dealing with what? The neonate first, right? Okay, so neonate usually admitted because of what problem?
The most common is respiratory.
Okay lah, respiratory infection could be congenital pneumonia, presumed sepsis. Okay, so those are the two common problems lah they admitted. So the antibiotic of choice when we start patient with presumed sepsis, congenital pneumonia is IV C-pen, C-penicillin and IV gentamicin. Why? There must be a reason why C-pen, why Genta started at the same time. So C-pen to cover for what? Gram positive lah. So what gram positive infection that common in babies?
Group B.
GBS Gambascola, or Group B Streptococcus. Okay, so Group B Streptococcus in mothers, they are common colonizer in the vaginal tract. So baby got GBS quite easily lah, especially those GBS mother who are not detected, not covered properly, so they can get early onset sepsis, late onset sepsis up to 3 months, 4 months of age lah. Even GBS meningitis can happen up to 3 months or 4 months of age. So C-pen will easily cover the infection lah, but you need the very high dose lah. So the dosage also important lah. Kalau small dose like 25,000 unit per kilo, 50,000 unit per kilo is very small lah. Usually we give about 100,000 unit per kilo. The dosage is not important lah, but the important here to know why we choose C-pen lah for neonate as a first line. Then Genta to cover for what? Gram negative lah. What are the common gram negative infection in babies? When you talk about vaginal tract, what are the gram negative? No, Listeria we start ampicillin. Klebsiella is not really vaginal tract infection lah. Okay, E. coli lah. E. coli is the most common UTI cause, right? So it covers gentamicin will cover for that lah, and plus ada gram negative lah. So yeah, simple as that lah. If second line, it depends on what antibiotic, what organism that common in that NICU itself. Okay, for here our second line is cefepime and vancomycin. Okay, because we have quite large number of Staphylococcus coagulans negative. So vancomycin, even though they are methicillin sensitive, yes, cloxacillin will cover lah, but sometimes we don't know they are methicillin sensitive or methicillin resistant. If MR cons, vancomycin will cover for it lah. Okay, so that's about NSU lah. Okay, but if got suspected Listeria, the first line is ampicillin lah instead of C-pen. Okay, alright. So that's about neonate antibiotic lah in short, in very brief. Okay, but if we talk pediatric age, like pneumonia, bronchopneumonia that we saw just now, even though we're treating for bronchiolitis, we also cover for infection, cover for bacterial infection. So the first line of antibiotic in pneumonia usually is what? Still C-pen. C-penicillin is still very commonly used everywhere. It's most of the time is the first line for most of the infection lah. But for bronchopneumonia is C-pen lah. It cover your commonly community acquired pneumonia like your strep. Your staph also we have some coverage as well. Okay, but you want better coverage like Staphylococcus, very severe infection Staphylococcus, you probably start IV Cloxa lah instead of C-penicillin. But here in PPUM we start ampicillin as the first line because ampicillin has better coverage of Haemophilus punya pneumonia, but non-type B lah. Type B we don't really cover because most of the child is vaccinated already. So dia tulis H1N. So kalau H1B is HIV lah, Haemophilus influenza type B. But H1N is a non-type B lah. So non-type B ampicillin will have better coverage lah. So recipe here choose ampicillin as a first choice. But if you go somewhere else, some other hospital pediatric ward, CPAN is still the first line for bronchopneumonia. Okay, because of strep pneumo and all that lah, still quite common. Okay, and then if you want to cover for atypical, then you need some different group of antibiotic lah. So different group of antibiotic for atypical is your macrolides, because macrolide have better coverage for with no antibiotic, the CPAN, cefuroxime, cephalosporin group, they are beta lactams. Okay, so they attack the cell wall, right? So the cell wall beta lactamase and all that inhibit all those beta lactams, so they are unable to maintain their cell wall, then they will get destroyed lah. Alright, but the atypical organism, they don't have cell wall, so you need direct invasion lah. So macrolide will do that. So azithromycin, your erythromycin, clarithromycin, those are under macrolide groups lah. Alright, so IV, azithro got IV lah, the rest all oral. Okay, so those who are the group that you have to suspect a typical infection, and especially pneumonia, school going age lah. So even though the patient is 3-4 years old, so you need to ask about the sick contact. If the sick contact comes from the school going age sister, mean the sister who got sick first, coughing very severely, sounds like infection, mother, parent, grandparent, who are the first one who fall sick first, then you probably want to cover lah. But there are other features as well for atypical. So it could be some eye discharge, could be a bit of rash, could be some X-ray finding lah. The X-ray finding looks worse compared to the clinical finding. Clinical looks quite alright, but X-ray looks quite bad. But you expect bad X-ray, bad patient lah, very severe infection. But somehow patient looks so well, just a bit of oxygen. That's one the common features of atypical symptoms lah. Okay, but in small babies, we probably add on. Sometimes we are unable to offer oxygen, the temperature still persistent, then you get the history that some contact, you might want to add azithromycin lah, or clarithromycin or erythromycin. For me, I choose the simplest, commonly available everywhere, so always erythromycin lah. Klinik got lah erythromycin. If you go to KK, mana ada clarithromycin ni? Okay, erythromycin is the oldest widely available one lah. Okay, so that cover for your CPAN, Genta, erythromycin, and then what else? So next, you know about the second line already. Then when we want to start or maintain and all that, maintain cefuroxime. Okay, so from the history as well, if patient already got some antibiotic from outside, for example, come in for pneumonia, already makan certain type of antibiotic like amoxicillin for example lah, and then makan for 1 week, good duration 1 week. Okay, then admitted because of pneumonia still not resolving or come in respiratory distress, so you might want to give a bit higher compared to your normal CPAN lah. So augmentin cefuroxime will be the next choice lah, because augmentin has a bit of additional thing, and it covers a bit wide range lah. It cover your gram pos, it cover your gram net, and some of the another one is called, I forgot already. Okay, never mind, you go check it out. So it covers some oral condition, common oral organism as well lah. Okay, cefuroxime also a bit wide coverage as well. It cover gram pos, gram net as well, and then so yeah, that's how we choose the antibiotic lah. Okay, so then what about those with third generation, fourth generation antibiotic lah, like cefepime, rosofin, meropenem and all that lah. So in hospital also, if patient like recently discharged from hospital or still in the hospital, have not been discharged for quite some time, come in with a new onset of fever, then you ask, got new symptom or secretion become a bit more tachypneic than baseline, then you probably suspect hospital-acquired infection lah. So hospital-acquired, you probably want to go for a bit higher generation lah, like could be tazocine, it could be cefepime, it could be ceftriaxone, could be meropenem lah. So in what usually they send this nasopharyngeal aspirate. Alright, so you see the bacterial, when you see the report, you need to see lah the report. Is it scanty growth? Is it lot of growth? How many pus cells is there? And then how many white cells count is there lah. So you need to determine this MPA growth, is it colonizer or is it infection? Is patient taken that time quite well, doesn't look like have any infection, you probably treat it as colonizer, because when you stay in hospital for quite some time already, you will certainly be colonized with the hospital bacteria on top of your normal common cells lah. Okay, yeah, your common cells, your staph, everything is common cells. Okay, a patient with chronic suppurative lung, they will have certain funny bacteria lah, like will colonize the lung lah, like those patient with CF, Klebsiella pneumonia, Pseudomonas aeruginosa is quite common colonizer lah in this group of patient. So the antibiotic of choice for this group of patient that come with exacerbation of CF or pneumonia or chronic suppurative lung disease, and then you probably want to start ceftazidime straight away lah, that one, because it covers Pseudomonas. Okay, but in the end you need to go trace all the previous MPA cultures, because when you see lah MPA cultures, if for example Klebsiella sensitive to amantine, then you go straight away amantine lah. So in the end, the cultures and sensitivity is quite important lah. We have many patients that are recurrently admitted, long-standing follow-up here, so you will have the records lah. Okay, but if you don't have the records, like patient goes somewhere else, somehow go jalan somewhere, got admitted somewhere else lah. So but you need to know, understand what is the underlying diagnosis, what are the common bacteria that associated with the diagnosis lah, like CF as I said just now. Okay, alright, then patient already on high grade antibiotic, for example cefepime, tazocine, but somehow still got another new onset of infection. So the next one, the higher end is always the meropenem lah. So patient come with if patient already on certain antibiotic, come with new onset, then the highest end dah tak ada anything else to cover, then meropenem is the most nuclear bomb that we have lah. Okay, so when you start meropenem, you take the culture. That's why the third generation onwards is very important to take cultures or maintain cephalosporin, and below you don't take cultures, nobody will bat an eye. Okay, but Rocephin onwards, tazocine onwards, cefepime must take culture, because you need to downgrade the antibiotic later. Okay, because even meropenem you start, you want to decide how long you want to give this meropenem. The longer you give very broad spectrum the antibiotic, the higher the chances they will develop resistance. Okay, so you want to give the shortest duration as possible, but you want to be efficient as well lah, the correct duration. If sensitive to meropenem, then you can continue lah for 1 week, 2 weeks, depends on what infection you. If you want to talk about duration antibiotic, that's another topic lah, because depend on what condition, the duration will be different lah. Alright, so when you talk about the choice antibiotic meropenem, other than hospital acquired infection that already patient acquired new onset, another common indication to start meropenem straight away is the patient come with very septic shock that require a lot of boluses, require a lot of fluid resusc, that indicates patient having severe and gram-negative sepsis lah. So patient come septic shock, you give bolus, but very difficult to push the BP up to 40 mils per kilo, 60 mils per kilo. Those are common features of gram-negative sepsis lah. Alright, another features of gram-negative sepsis, they are ill in a very short period of space of time. It's like yesterday okay, today come very bad. Okay, so those are typical features of gram-neg lah. If you give gram-neg sepsis features like that, you straight away bomb with meropenem lah. You cover straight away the thing that can cover everything. After that, you take the blood culture. Before you give, you take the blood culture. You see the sensitivity after that lah. Okay. Alright. So yeah, patient come neutropenic shock and all that. Meropenem is always the first line. So patient come, patient has underlying cancer, whatever. or post chemo 1 week ago. Typical history. 1 week later come with fever. Some come with fever early. They may not go into septic shock yet. So you probably treat as neutropenic sepsis, but not in shock yet lah. If not in shock, you probably can start tazocine first lah. They have their protocol lah. Not in shock, tazo. Patient in shock already, miro. Okay. Okay, I think that cover briefly lah the basically how you want to decide the antibiotic lah. Okay. Alright, question. Okay lah, for certain antibiotic also it depends on the infection lah. If UTI, you want to probably start augmentin, cefuroxime, depends on sensitivity lah. But most of the time it's either augmentin, cefuroxime will cover the urine tract infection lah because of the gram neck punya coverage. Okay, you don't start CPAN lah for UTI. Okay. Then for skin infection, I asked you already lah. Skin infection, cellulitis, antibiotic of choice you want to start. I already give you the common source just now. Cloxal lah. Cloxal is the first line lah. Cellulitis merah skin, start Cloxal lah. You won't be wrong. Okay. Ear infection, throat infection, antibiotic. Can. Amoxicillin also cover, but if the exudative tonsillitis, you probably want to cover a bit more lah. You want some gram-negative sepsis first, gram-negative bacteria coverage as well lah. Alright. So you want to start Flagyl. Flagyl cover for what? Metronidazole.
Parasite.
No. Anaerobic. Yeah. So that's another thing that I was looking for, the words anaerobic lah. Augmentin also have a bit of anaerobic covers on top of your gram neck. Because oral got a lot of anaerobes. Okay. So augmentin, cefuroxime, they have some anaerobes cover lah. That's why augmentin is very famous with oral infection, ENTs people, ears infection. Okay. Yeah. Okay. I think that's all lah. Finish.
Thank you.